We're excited. We're excited that you're joining us. I've seen people joining from many parts of Kenya, other parts of Africa. I'm seeing people joining from the UK, from India, and I'm sure the names that I'm not familiar with are from Canada and other parts of the world as well. But we are very excited to have all of you joining us this evening. Some of the participants are joining on Facebook, so we have another crowd joining on Facebook. But this evening we have two very important speakers to really teach us, well, not teach us, but to share with us what compassionate community is about. This is a movement that has been going on in some parts of the world that I think we also can learn from and borrow from and see how we can bring back, that compassion into our communities, especially when we're taking care of people with life-threatening illnesses. So to introduce myself, I'm Zipporah Ali Zippy. Most of you who know me as Zippy. I am retired from Kenya Hospices and Palliative Care Association, where I worked as the ED for over 15 years. I'm a palliative care physician. Currently, I'm the chair of the NCD Alliance of Kenya, but also a private consultant on many health issues. So today we have, like I said, two very interesting people who are going to be speaking to us. Actually, they are friends, not just people. Both Dr. Libby and Bonnie serve on the Public Health Palliative Care International, and I'm also a member of the same board, on the board of Public Health Palliative Care International. I know I'm a very quiet member because meetings are usually held at midnight, so I'm usually asleep. But I'm so happy that they agreed to give this session when I talk to them. So they will be giving us this session. I'll just read a little bit of their bios because they're also both of them very accomplished people. So Dr. Libby Salno is the first speaker, and Dr. Libby is a palliative care medicine consultant with the CNWL NHS. She will tell us what those are. Trust in London, UK, and is an honorary senior lecturer at St. Christopher's Hospice. And most of you, many of you have gone through St. Christopher's Hospice, and I went through there in 2000, I think around 2000 there. And UCL Marie Curie Palliative Care Research Department, UK. Her PhD explored the impacts of compassionate communities. She has published articles and book chapters in this field, and co-edited the book International Perspectives on Public Health and Palliative Care. Dr. Libby, I hope you'll tell us where we can get that book. In 2011, she has supported the development of the international movement in new public health approaches, is vice president of the Public Health Palliative Care International, honorary consultant with the WHO Collaborating Center for Palliative Care in Kerala, India, and the president of the Palliative Care section of the Royal Society of Medicine. So you can see that we have very accomplished speakers this evening. Karibu sana. In Kenya, we say karibu sana. Dr. Libby, I think you were in Uganda at one time or not. Do you remember any Swahili? Karibu means welcome. Karibu sana. Yeah. So our next speaker, also very accomplished, is Bonnie Tompkins. Bonnie works at Pallium Canada and is a public health professional whose work mobilizes compassionate communities across Canada and focuses on the community and their role in supporting those experiencing serious illness, caregiving, dying, and grieving. Bonnie has led community-level initiatives across Canada and is an active contributor to compassionate communities work internationally. She is a council member of the Public Health Palliative Care International Association and contributor to Cancer and Work in Canada. Bonnie has been a strong advocate for the Compassionate of Communities movement since the release of a Compassionate City Charter in 2015. So I hope you'll also be able to share that charter with us, Bonnie. So thank you very much, ladies, for agreeing to speak to us. Some of you are actually at odd hours in your own countries, but I'm so glad that you agreed to speak to us on compassionate communities. So, like I said, we have many participants. It will not be possible for us to ask all of them to introduce themselves. We run out of time, but please, participants, introduce yourself on the chat, where you're from and your background, so that we can also know who you are. We will have a Q&A session at the end of the meeting, of the webinar. Please put your questions in the Q&A section and we'll be able to respond to them. Thank you so much, Libby. The ball is in your court.
Self off mute. Can everyone see that? Is that clear? So thank you so much, first of all, Zippy, for the invitation. It's great. We've been working, the three of us and others, on the Public Health Palliative Care International Board, and it's a lot of work, and we often are meeting at odd hours. So it's nice to actually be able to share as colleagues with some of our interests and our specialties. Zippy, I've already recruited to give some talks for me for one of the fellowships that we work on, so I'm happy to be able to repay the favour. It was a great talk you gave, Zippy, so I hope to be able to stand up to your standards there. And I can see from the chat there's some people, old friends and new, so do please introduce yourselves, put any questions, any of the comments that you want me to pick up at the end. I will go through that, and I'll try and put some of the links to some of the papers and things I reference into the chat at the end during Bonnie's talk, just so that some of them are there, because I think it's really great to have the opportunity to read some of the papers. I'll just be touching on them briefly. So as Zippy said, I'm a palliative medicine consultant. I've just rushed back from a home visit for this to get here on time. So I'm very much 1 foot in practice, but also I'm an academic in my other part. So specifically focusing on the role that communities play in end-of-life care, and looking at how professionals, families, the broader neighbourhood community can all work together to support people at what are universal experiences for us all. You know, death and dying is not specialist in many ways, and it will happen to all of us, and all of our family members and friends at different times will experience loss, grief, caring. So these are key issues that are everyone's responsibility. So that's really my driver for understanding how lay and professional networks of care can really support people at these times. So the objectives that I thought would be good to cover today, first to look at the reasons for why there's the increasing interest in new public health approaches, compassionate community approaches, health promoting approaches. These terms are often the ones that are being used now and applied to end-of-life care or palliative care. To understand the principles of this approach, like what is this and what's the research base, which has really increased in recent years. And I'll look at some of the key papers that are informing our understanding. And then finally, to understand how this works in practice. And that's, I'm a pragmatist. You know, how do we begin using some of the evidence that is building in the literature, or some of the experiences that we see in our everyday practice? How can we begin using this to build essentially a new model or a wider model of care, and in the different contexts around the world? So first of all, just to think about what public health means, because this term is used a lot, and there are many different definitions of public health, but broadly it goes beyond that individual patient. It's looking at the broader way of either preventing disease, prolonging life, and improving well-being, promoting health through the organised efforts of society. So by definition, this is explaining this is beyond medications, surgical interventions, clinical interventions. It looks at those broader issues for which the whole of society is involved in. Now this graph looks a bit complicated and quite busy at the beginning, but actually I think this is really key in helping us shift our focus from bedside clinical interventions to what a public health intervention looks like. And I can put this paper into the chat after. It's a paper I published a few years ago with some colleagues. And so looking at the top right-hand one here, the patient care or kind of bedside perspective, when you are looking at a patient who, say, comes with breathlessness in the bed in front of you, or in the home in front of you, you're not worried about the whole subsection of the population who doesn't have breathlessness. They're not relevant. So you're looking at this small grey box here of those patients who have this symptom, who have pain, who have breathlessness. And they're your focus of intervention. And any intervention that you do, so using handheld fans, using cautious opioids, looking at breathlessness management techniques, they only will have an impact on patients or people who've got that condition. And so in the graph underneath it, you see there's an improvement. So the number of people with that symptom has decreased because of your intervention. So this could be a good example of, say, a breathlessness service or a pain management service or even a palliative care service, where you have your defined population with a condition, you devise an intervention to improve that condition, and you hope then after that people would be have less of that symptom and would have their quality of life improved. So that's the bedside clinical kind of one-on-one interaction. Moving over to this left-hand side, you've got a public health perspective. Now that by definition includes everyone in that community. So we're looking at a much broader way. You're looking at the whole of society, people who have not got it yet, because they will be those who we could prevent something happening in, people who might have it, but quite mildly, whatever this condition is, you may be able to improve their experience. And then people who may have kind of the serious or last stages, end stages of something. So this goes for cardiac, heart health, reducing smoking, improving nutrition. This is for all different conditions. You look at the whole of the population. And so then if we think about this in end-of-life care, we're not only looking at people who are who have a life-limiting condition and are in the last weeks of life or last days of life. We're looking at the whole of society, those who don't have that life-limiting condition. Because grief, loss, and essentially death, mortality are universal, everyone will have an interaction with this at some point. So this comes to the really crucial diagram here, which is any intervention, any public health intervention for end-of-life care, for palliative care, must affect the whole of the society, the whole population, because you then want to change the whole population's ability to support someone who is grieving, to support someone who is dying, to know how to care for someone at the end of life or how to support the carers. So those kind of interventions are very different to that one-on-one interaction that you might have with a patient or with a group of patients. And the principles of public health. So as those graphs demonstrate, they focus on populations rather than individuals. And it looks beyond just people who specifically might be on your patient caseload to look at the broader society in which they live in. And there's three means of intervention for public health: prevention, early intervention, and harm reduction. And those three pillars of public health have relevance throughout end-of-life care. People often think that the idea of having public health and palliative care don't make sense because you can't prevent mortality. Well, we're not looking to stop people dying. We know that's a natural part of many illnesses, but what we're looking for is to reduce suffering, reduce carer burnout, reduce depression, difficulties after bereavement. So those things can be prevented. You can intervene early, and you can harm reduce for all of those and all of the other issues that could go with life-limiting diseases. When we think about the term public health and palliative care, it has a great deal of different wide-ranging implications. One of the key ones that we'll look at briefly is around opioid access and access to services. And the Lancet Commission on Pain Relief and Palliative Care, published in 2017, was very clear in setting out the stark inequity really with access to opioids and how it's very difficult to develop a palliative care service without rectifying that as people are dying in pain. So often when we look at kind of global needs and needs within countries, you're looking at really clear indicators like availability of services and opioid access. The WHO has pushed a public health approach from the beginning, really, mainly focusing more on kind of the traditional end of public health, which is around mainstreaming palliative care, integrating palliative care into mainstream services from primary care through to tertiary hospital care. It's focused on developing opioid access, and that's been a key part. Initially in the 90s, it was focused on cancer pain and cancer patients, but that has seen a huge widening in recent years. And the WHA, the World Health Assembly resolution in 2014, which said that palliative care is part of comprehensive healthcare throughout the life course, was a really key document in really kind of grounding a public health approach. This is not something that's specialist, only available for some people. There's a kind of clinical intervention. This is something that should be available throughout the life course for all people. And when we look more broadly, so moving beyond, say, some of the more traditional public health applications around access to services, availability of services, you can start looking at some of the participatory approaches. And that's where most of the rest of this talk is going to focus on, looking at these new public health approaches and how we engage with people who are living with diseases, who are caring, who are experiencing this in a day-to-day way, how we can include them as partners in the care that we deliver. And that leads us on to the social determinants of health, which is something that certainly the WHO has really pushed and is becoming much more common parlance in recent years, to say that actually health services only create, there's a lot of statistics and recent papers to say that health services only create about 10 to 20% of improved health outcomes, and the remaining 80 to 90% is by their environment. And this makes sense to me as a clinician, as I go out to see patients at home. The medication I give has some benefit, but actually the home they live in, the food they're eating, the air they're breathing, the family who are supporting them or unable to support them, those things have much more of an impact on those big health outcomes often than the tablets that I can give. So that's kind of some of the range of how public health might be attributed to palliative care. And we're going to look in a bit more detail in some of these aspects now. So keeping with the kind of traditional end, and I mentioned opioid access, there is a stark inequity, and many of you will have seen the map which shows many countries bloated with opioid use, where patients have more opioids than they need, and other countries have been essentially removed from the map as there is no opioid availability for those countries. And that was published by the Lancet Commission, which is the reference at the bottom, to demonstrate that of the 298 0.5 metric tons of morphine distributed per annum, only 0.1 is in low-income settings. It's one of the stark inequities and a failing of global health. And some of the other figures back in 2013 demonstrated that of the 100 million people who need palliative care each year, only 8 million have access to it, and that there's a huge discrepancy where the majority of those who need things like opioids do not have access to it. So I'm going to talk through three key WHO documents that I think really help bring us along to understand what these new participatory approaches or new public health approaches, how they developed. The first thing to say is that they're not new. Back in 1978, there was a declaration of Alma Ata, which was around primary care, but looked broadly at healthcare. And it was very clear to say that healthcare and primary healthcare should not be delivered in a way that encourages dependence, in a way that is kind of top down and people are told what to do. It should be done in a spirit of self-reliance and self-determination, so people are in charge and in control of their own health, that actually it's their responsibility and they're empowered to make the right choices and to take action over their own health, rather than kind of passively receiving tablets or passively receiving care that they're not active participants in. So this idea of participation came in with this early declaration. Then 30 years later, in 2018, this was revisited by the WHO with the Declaration of Astana that many of you may have heard of when it was released 3 years ago. And this looks at primary care and healthcare throughout the life course. And crucially, they stipulate and include palliative care. So it's from birth through to palliative care. So it's, again, really embedding palliative care as part of the care throughout the life course. It's an essential component along with maternity and child health. And they list some of the key players in developing health: governments and societies, obviously primary healthcare and health services, but also enabling health conducive environments, kind of tackling or getting to the grips with the social determinants of health. You know, these have a huge impact on how health and well-being are experienced or achieved. And the partners and stakeholders, there need to be a broad range of stakeholders in promoting health. So this is another important declaration. And then finally, the Ottawa Charter in 1986. Again, a kind of a forerunner really for the social determinants of health, saying if you want to improve health, you need to look at improving it across these 5 pillars or these 5 dimensions. So you need supportive policies, you need public policies that promote health, that promote smoking cessation, healthy eating alongside opioid availability. So you need these broad public policies that support health. You need to create supportive environments. So this can be around green space, clean air, mental health. Is a lot of information around cities and how poor they are for mental health and how you increase green space. Dementia-friendly communities, whereby you're trying to support people with clear signs, with different things to support people to allow them to continue to interact. So how you can change environments to make them more health enabling. Strengthening community action, and this is where really the compassionate communities sit, how you support communities to use their skills and their resources to care for those around them. Developing personal skills is often around knowledge, so people have the information they need, which can be very powerful to then make those choices, the right choice for them. And to reorientate health services from this kind of pure acute care model, whereby people are just brought into hospital, lots of tests, often particularly with non-communicable diseases, NCDs, there is no cure. So trying to look at how you can reorientate health services from this pure acute model to preventative and a long-term model, often which involves a very different set of skills and services than kind of the acute hospital. So the Ottawa Charter has been really key in redefining how people see health and where we should be focusing our resources. So building on these and other documents, the principles of new public health are that it is participatory. And so this is not about experts telling people what to do and kind of top-down approaches where a new document comes out and this is what people do. This is about involving people who are living, experiencing these conditions, living in communities, and have a very different set of expertise to the professional expertise. It focuses on social justice and social change. It's not static, it's trying to challenge inequities. It is based on and built on partnerships between professionals and communities. It's not about communities being given the remit to care for everyone and almost taking over with that. Professionals always have a role. And so it's about partnerships and supporting people. Communities can often feel slightly overwhelmed if you kind of begin talking about things just being taken over by them. It's not about a withdrawal of professionals, but how partnerships can work well. Looks beyond biomedical perspectives and to include the social determinants of health and important links to primary and universal healthcare. And there's a growing evidence base. So I'll run through some of the papers, but I will put these into the chat. So this is a really key article that was published in 2010 by Julianne Holt-Lundstad. And what they wanted to do was there have been lots of smaller studies to suggest that the more socially connected you were, the more of a network you had, the better your health outcomes were. And this could be around cardiovascular disease, mortality they looked at. So they did a big meta-analysis with over 300,000 patients to have a kind of final word on what is the link. And this is the graph that they came up with, which is quite compelling. So at the bottom, and this graph demonstrates the bigger the black line, the more protective the intervention is for health. So the more effective it is at reducing mortality or improving survival. So reducing air pollution, reducing someone's BMI through projects, having cardiac rehab after you've had with a congestive cardiac disease, giving the flu vaccine, this is obviously pre-COVID, smoking cessation, so stopping smoking if you're smoking cigarettes to reduce it to under 15 a day. And so all of these are dwarfed by the huge impact of having social relationships. So if you do not have social relationships, this essentially confers a 50% reduction in your survival. And this was so compelling and it outweighs all the other public health interventions. And what they showed also was a dose response. So when you just had binary, whether you were married or whether you lived with someone else, that showed an improvement in your survival. But if you had more complex measures, which demonstrated multiple relationships and lots of different strong relationships, that was even more protective. So it was a dose response relationship. So this was a really key paper in making us understand the social nature of health. Nicholas Christakis has published these two, published a huge amount around the role of social networks in health. And he, through a longitudinal study over 32 years, where they looked at offspring from the original cohort. So they had a huge data set of people in the USA. And here they looked at how behavioural patterns and such as smoking and issues such as obesity changed throughout this. And what they noticed is that it spread through networks. So friendship groups or networks began to stop smoking, and that entire network would then stop smoking. And similarly, you saw this spread through. So actually it was the networks that were influencing people's behavior. And similarly with obesity, the obesity began increasing through networks. And you could see that working through. So these papers, again, are really interesting to see the spread and demonstrating that actually this social nature of our decision-making, of our health, is really intimately related to the social networks that we belong to. And this has been used in end-of-life care. So this is a paper from some colleagues of ours in Australia, and they began looking at the role of social networks at the end of life. And often the idea, the narratives, is that caring at the end of life can be draining, it's a burden, people feel they have burnout. But they did an intervention where they supported carers with a mentor who knew about caring for someone at the end of life, could link them in their community with the right people, the pharmacist, other people, build a network around them. And they showed that actually here on the left is a carer who the nodes are, the red dots are carers, people, and the blue is the carer. And there's few relationships in this one on the left. And after this intervention and after the patient had died, actually they had developed new relationships, further relationships, and they'd become more intense and supported in nature. So by using an intervention that builds networks around people, you can actually challenge this narrative and these experiences that caring is a negative process. And this is a systematic review that I undertook with some colleagues in 2016. And here I was trying to gather some of the evidence around particularly compassionate communities or community action, that single pillar of the Ottawa Charter. And we demonstrated that not only were the impacts for the individual, so you're more likely to die under a palliative care service if you had a strong network, you're more likely to die at home or in your preferred place of care. Carers were less likely to feel burnt out and to have more support. And there was a ripple effect. So when you had a large community network, the skills that people had used for caring for that person were then used in future experiences, not necessarily in end-of-life care, but for other areas, child health, vaccination, literacy. These skills were transferable. And this paper was one published in 2018 in the UK, which showed that if you developed a network around people who were having frequent admissions and bouncing into hospital frequently, when they came out, if you initiated a network supporting them with the resources in their local community, their readmission rate really dropped, whilst the control groups around that increased. So again, so there's many different studies that are emerging that are demonstrating that actually by harnessing the power of social networks, social relationships, or social capital, you can begin influencing people's health outcomes, their quality of life, and their experience at the end of life. This is a model, a diagram that I think is really helpful. You may have seen it, and it demonstrates the kind of interconnected nature of different initiatives in palliative care. And right down at the bottom, there's specialist palliative care, which is quite a small cog. Not every death in a country is going to come under specialist palliative care. We would have to so dramatically increase the number of specialists, but it isn't needed because this is for complex kind of inpatient referral, complex pain, complex symptom control, complex psychosocial issues. But that's a minority of patients. For the majority of patients, generalist palliative care is sufficient. That can manage symptoms, do advanced care planning, support the family. And so that cog is bigger, and that would be run by general practitioners or generalists in hospital. The next one up is larger and is compassionate communities. So these are community networks that exist around people who are dying or within communities to support grief, loss, caring. And they exist either around specific individuals who've started up, specific organizations. And then coming up to the final one, which is the largest one, is the Compassionate City Charter. And this is more of a civic program. So this would be run by the mayor or the council and would get everyone in that community. And it would be not around specialist care, but looking at how do we talk about death and dying? How are we supporting people who are bereaved? Do children understand what needs to be taught through schools? How can people volunteer and take a more active role? So that, I think, is quite a helpful model for kind of thinking all of these are crucial. And as you can see, they're cogs. So if one of these is not working, then you're not going to get the full benefit of all of this. All of these components should be present in a community or in a town, in a society, to allow us to really care for people in the best way. So Alan Kelleher is kind of the key thinker in this field. He was thinking about this back in 1999 when he first described the idea of a public health approach to palliative care or end-of-life care. And he aligned these two kind of paradoxical disciplines. A lot of people, as I said before, didn't think it made sense to think about a public health approach because you can't reduce people's risk of dying if they already have a serious illness. But as we said, it's not about reducing mortality for its own sake. It's reducing everything that goes with that and the distress and suffering that that we all can see. In compassionate communities, he described in his book, Compassionate Cities there, and they are community development initiatives that actively involve citizens in their own end-of-life care. And he specifically chose the word citizens in this because it is around being, having both rights and responsibilities in the society that you live in, and that this is something that affects everyone. This isn't an optional thing to participate in. Everyone at some point will be touched by this. And they aim to build partnerships between services and communities to build on the strengths that each possess, rather than just replacing them with professional care. So it's not either or, it's how can we build networks between them. And as Zippy mentioned, we are part of the Public Health Palliative Care International, and this is now the kind of umbrella organisation that is pulling together globally the different examples of this practice around the world, and increasingly through the conferences that happen every 2 years, we're really seeing this proliferation of experiences of projects around, and I know Bonnie's going to mention some of them in some more detail. I'm just going to talk now briefly in the last part about my experiences in trying to understand what makes a compassionate community, what's transferable, how can we begin using these in different contexts. And I've spent a long time working with Dr. Suresh Kumar, who many of you may know, who started the Neighbourhood Network in Palliative Care in the southeastern state of Kerala in India. And there they've really radically overhauled palliative care. Coverage has improved from under 1% of those in need to over 70%. They've reformed the narcotic laws so that opioids are available, provides high quality care delivered by doctors, nurses and volunteers and in people's homes, and they're a WHO collaborating centre. So the way the Neighbourhood Network works is that there's a network of different sites, different projects that are owned by that local community. So although there's an umbrella organisation that helps with training and getting doctors and nurses, each community owns its own project. And the key thing about this is whilst it's developing palliative care and delivering services and care to people, it also sees participation as an end in itself. And so the processes around building people's capacity to respond to health issues, to advocate, to challenge issues, is one of the key outcomes as well as providing palliative care services to those in need. So it's a community development project. There's over 10,000 trained volunteers throughout the state, and they are key people. And this is some pictures of some volunteers with nurses. They're a key part of the community of the response. So the nurses and doctors may well be doing a lot more of the medical and clinical advice, and the volunteers are there supporting with the psychosocial, spiritual, and visiting more frequently to support the family and the carers in their own homes. So having spent a long time working with this neighbourhood network and being told how specific it was to Kerala and how this was something that would not work outside of that very specific setting, and how things were different in different countries, and this would not be something that was translatable. So we wanted to understand that. I wanted to challenge that and look at what learning we could take from how this has been set up, how people respond when they're asked if they would like to support caring for people at the end of life. And we started a project called Compassionate Neighbours in the United Kingdom in London. So we started it in Hackney, which is an area in East London with a strong history of community development, of advocacy, of action. And we started this project we went out to communities, different communities, and asked them, is caring for someone at the end of life important? Do you think we've got it right? Is there things that we could do better? What's your role, and what do you think a compassionate response to people dying should be? And we had an overwhelming response. People wanted to get involved. People were really keen. And that was one of the first things to kind of deal with the criticism or the feeling that this wouldn't work. People were really interested, and we had waiting lists for all of our programs to take part. So Compassionate Neighbours is a project that recruits community members to become compassionate neighbours. And this is crucially the role of a neighbour and not a professional. So this is not training community health workers, peer support workers with a specific service involved. This is around what the role of a good neighbour is. And we use this term because everyone knows what a role of a good neighbour is, whether you're able to enact it or not. It's a term that everyone knows what that means. And so the role was, how do we support each other to be the best neighbours, the compassionate neighbours for people living locally in the village, on your road, in your apartment block, kind of very local. And the intervention was to support people as friends rather than kind of coming and delivering a kind of a befriending service, which is often a lot in the UK, where you kind of have a kind of 12-week match with someone, a volunteer, and then that ends. And we were looking at much more sustainable relationships and trying to build some of these social networks that I've mentioned before. How could we begin to create those for people who just don't have them? Their families may have moved away, they may be very old, and many of their family and friends may have died. So for those people who don't have this social network, what can we do to create that? And the aim is beyond that individual relationship as well, that kind of ripple effect, with the aim of making communities more compassionate places to both live and die. It was based on a community development model, as with the neighbourhood network and palliative care in Kerala, and we've taken that really clearly. So this isn't just around giving support to people at the end of life, but it's about developing the compassionate neighbours themselves, the volunteers, so that they've got skills to go on and tackle things in their local neighbourhood. And we saw that after people have gone through the training, which is very much around advocacy, understanding your own skills, understanding your own issues of loss and grief, people felt very empowered and went out and they began volunteering for maternity services, challenging a lot of the health services to make them more accessible. So we saw this kind of ripple effect. People felt empowered to go and challenge some other things that weren't right and weren't meeting their needs. And it was a partnership between a hospice where I was working in East London and also a community advocacy charity. So we had that kind of grassroots advocacy charity as well, because often institutions don't know how to begin working in a more participatory, equitable way. So it was really helpful to have this quite radical community charity to hold a mirror up to a lot of our practices and how hospices were actually excluding a lot of people who couldn't come for various reasons, and how we could also use this project to start challenging the kind of very professionally led model of hospice care to open it up to people who weren't able to access it. So it starts with dialogue with the local community. This is not about doing to, but it's about asking the question, what works, what doesn't work here, what would be better, and what role would you like in that? And as a result, we got a very different demographic to the traditional demographic, which is often older, female, retired. We got lots of young students, people working, mothers whose children were in school, people wanting to take action. We did training over 4 weeks in groups, and the key thing was building a network of those volunteers, so they had that support. And rather than looking at flowcharts and lists of what you could and couldn't do, we were looking much more in a kind of common sense way. Okay, what would you do if your neighbour tripped over and fell? You know, rather than thinking about the flowcharts, well, you'd either call an ambulance or you'd call a GP or you would call their family members to support that. So we were trying to think through kind of ideas of risk and safety and boundaries, not professional led models of care. We were looking at the difference between the responsibility of the hospice and the community. So where did the responsibility, the ownership for this lie? And for some people who volunteered, we linked them with people at the end of life in the community. Others took on this advocacy role, and others, it was a real personal change that they experienced. They took that off into other areas. So my final slide, be interesting to think, you know, I pose the question back to you now. What would a Kenyan interpretation look like? This will already exist in many settings around, in cities and villages. This will be, it's happening already. But the question is, how can you make sure that it's available for everyone, for people who may not have a great social network set up around them? How could you begin developing this? And how could you build the confidence of those social networks that do already exist, that are doing so much already? How could professionals link in and support those? This work goes beyond palliative care and beyond just service provision. It looks at social justice, equity, social capital, which are issues that we cannot avoid within healthcare. And the question I'm always asking myself within this, what role do hospices, palliative care services, primary care services play in this? And what role does society? Where's the kind of catalyst? Is that our role, that we're there to kind of create a platform for these things to come together and for people to begin asking these questions and taking action? And how do we work with citizens, patients and families as equal partners? And I think that's one of the issues that often we have as healthcare professionals, that we unwittingly take over. And how can we ensure that we are not going in and kind of taking over? And I often, one of the questions I ask when I go to see patients is, you know, who's supported you before? How have you got over challenges in your life before? Because I want to draw them in. I don't want to kind of replace with my army of different healthcare professionals, because we will step back when that patient dies and they will not be left then with any support. So the question is, how can you bring in the support that's always been there through relationship issues or job issues or problems with children? How can you bring in that support, and how can we integrate that with excellent professional palliative care? Thank you.
Sorry. Thank you so much, Libby. That was really, really a great presentation. I think we are learning so much from it. Thank you so much. And we'll probably ask questions later on. And thank you for really, just before everybody else joined onto this call, Dr. Libby came in breathless. She ran to come and give this session. We actually even thought she's not going to make it, and she made it. So thank you so much for even running in breathless and giving us this session. And you talked about very interesting things, very important things. And maybe just for I gave Bonnie time to start off, I'll just share what happened this morning, because I was driving into the estate, and I noticed one of my neighbors was being held by a gentleman on the left, another on the right, and taking very tiny, slow steps. And I had seen him a few weeks ago, and he was okay. And I mean, a month or so ago, he was okay. And so I called the wife and asked, what's going on? And she said, oh, my husband fell. He had a bleed. He was in hospital for 3 weeks in ICU. And I was like, we are neighbors. We literally not very many big families where we are living. How come nobody, I don't know about this, nobody knows? And she said, I was so scared to call anybody because I didn't know how people would react, if they would want to, you know, help or not. I didn't want to take your time, and I felt so bad. And I went to see her, actually. I went to see them, and we were so excited when I went to see them. So I think as much as I know Africans, we like to say we take care of our own, we don't. People are scared to come and ask us to help them out, to even just visit them. So this is just also to now introduce Bonnie in her topic. Maybe she'll talk more a little bit about that, but thank you so much, Libby. Bonnie, please, the floor is yours now.
Thank you. Can everybody see my screen?
Yes, can you just put it to a slideshow? We can see it.
Yes.
Thank you.
Perfect. Yes, so thank you for having me. And so I'm going to dive a bit more into the compassionate communities movement and sort of the action part of compassionate communities. So building off of Libby's great presentation. So what are we going to cover today? So we're going to talk a bit around compassionate communities and what are they? What does a compassionate community look like? That's a question I often get. How to support the growth of a compassionate community. So how can you support that growth? Going to talk about some examples at all different levels. Going to mention the World Compassionate Communities Day that's coming up. I will be sharing free resources. I know I've seen that in the chat around accessing resources to help you start your own initiative. So I will be sharing a bunch of resources as well. And then a few little tips to sort of keep in mind if you want to engage with the compassionate communities movement. So compassionate communities, what are they? As Libby has already sort of mentioned, they are local citizen-led social change initiatives. So the way that I think about it, so Libby's talked about public health palliative care, right? I see that sort of as the umbrella, and compassionate communities movement is just one of the initiatives that citizens can engage in. So it's really about citizens anywhere across the world taking action to create a more supportive environment. So whether they're in a city, they're in a community, a neighborhood, it's an online community, it doesn't matter. So this movement of compassionate communities and compassionate cities is allowing us to take action. So empowering citizens to improve improve the experiences of those who are caregiving, dying, dealing with serious illness, grieving. So as mentioned, really creating that local supportive network. And that's the key equation there, or the key piece, is that it's local. And really compassionate communities support that sort of 95% rule. The idea that members who are dealing with these experiences, they spend 95% of their time outside the formal healthcare system, right? So how can we support them? How can we make that experience better? As Libby said, we can't take things away, but we can make it better. And so compassionate communities is about taking action and creating a more supportive environment for anyone who's dealing with those experiences. The other thing that I think is important, and again, Libby sort of mentioned it a few times in her presentations, the compassionate communities movement, each initiative around the world is unique, because one is, sometimes they're in cities, sometimes they're in neighborhoods. And then also what goes on in the local context, they're also very different. There's often common themes that exist within them, but how they approach it, what they choose to focus on, it is quite different. So just to give a bit of an example, so in Canada, the approach that we're taking around the compassionate communities movement is that we believe that a community is any group of people have something in common. And so what we really try to nurture in Canada is, it could be an online group, as I mentioned, it could be a neighborhood, or it could be a whole city that takes on the initiative. So what we're really trying to do is make it inclusive, so anybody can work to create that more supportive environment. If you'd like to review our definition, the link is here if you'd like to learn more about that Canadian context. So what does a compassionate community look like? And so, as I mentioned, they're unique, but they all sort of have these fundamental things. And so here's some of them. One is, again, as you have already heard, but that these experiences are a part of everybody's journey through life. So members in that community, they understand that, and they understand that they can happen at any time, right? It's not just seniors who are impacted, it's young children, for instance, who are impacted. The idea that caring for one another is everybody's responsibility, that it's not just healthcare or social services, and that they strive to be inclusive of all members in the community. So that means, people who may be living in homeless shelters, or people who are living like in a women's shelter, tattoo parlors, people who are covered in tattoos, so we really got to think about not turning anyone away. Everybody has a role to play here, and being inclusive. CC initiatives, they strive to include all the settings in the community, organizations, and associations. And so this one really applies to the Compassionate Cities movement, which is, as Libby had mentioned, is sort of a higher level. It's more intricate. It's really ensuring that connection all throughout the community. And usually the local municipality, so the mayor or what have you, they have a key role to play in that. And can't say it enough, because you've heard it a few times now from the both of us, that they are led by local citizens. Like, this is the fundamental piece to compassionate communities, and ultimately to its success and sustainability, is that they're led by local citizens, and that the CC activities are delivered in the community setting, right? And so, I think Libby brought up the idea that sometimes healthcare professionals get involved, and sometimes they have a hard time sort of understanding their role. And we have seen, or I have seen around the world, where all of a sudden programming is happening in the hospital. But truly, CC, Compassionate Community Initiatives, their activities, they need to be closer to where the people are who you're trying to support, or you're trying to create that supportive environment for. So that's really a fundamental thing to think about if you're starting a compassionate community or a compassionate city is, you know, is this close to the people who want to access it or the people we're trying to support? And if it's not, then you may need to think about that. So next we'll look at how can you support the compassionate communities movement itself, right? The growth of it. So I've basically taken two approaches here. And this is something that certainly at Pallium Canada, where we support the movement across Canada, we really try to help people think about is what can you do at an individual level? What can you do as a person? And then what can you do if maybe you're attached to an organization, right? Or you're in a workplace. So that's the approach that I've used here. And I'd really encourage you to think about that yourself is what can I do as an individual? And then if I'm involved in associations or I have a workplace, what can I do in those other settings? So as an individual, the biggest thing I can say is to explore the resources that I've included in here. Libby's going to give links to some of the research papers, but learn more. Visit PHPCI's website. That's the biggest thing I can say, because this movement is evolving, even though, you know, it's been around for quite a few years, but it just continues to evolve. And certainly COVID has impacted that. And so there's been a big shift in that as well to online. Spread the word about the compassionate communities movement. I often said when I worked on the ground, I planted the seed with anyone who would listen. The big joke in my early years on my report card in elementary school was that she talks too much. And so I feel this has served me well when it comes to this idea of planting the seed. Please talk to anyone who will listen. And then look at having some local conversations to see if there's an interest in starting the initiative, right? So maybe you're a part of a faith community. And so maybe have a conversation at your local church and see, is there an interest in starting a compassionate community movement? Play a leadership role within an initiative. So if one's moving forward, get involved, or play a leadership role around spreading the movement in an area, right? So maybe you're at a part of an organization who's at a higher level. And so see about getting involved and supporting it at that higher level. I put a superhero here because one of the recent projects I've been involved in, which is highlighted at the end of this presentation, when we were doing our research, what we kept coming across was the idea that those leading community change, social change, culture change at the community level, so those citizens, that they're actually superheroes because they're often doing it, they're volunteering their time, they're doing it maybe off the side of their work desk. And so the idea is that they're superheroes, and we need to sort of remind them of that they're doing great things and you know, keep up that work. So then let's look at that organizational level. So what could you do again if you're attached to a bigger entity? So again, still learn about the movement, right? Support those who are thinking about starting a compassionate community. So for example, maybe you're working with a hospice and you've heard in the community that there's an interest to start one, right? So support them. Support initiatives with resources. So that's a role organizations or associations can play, whether it's tangible resources like providing them a space to meet, or maybe a bit of admin support, right? Or funding. I'll speak about an example here that happens in Canada where they provide seed grant funding. So maybe you provide a little bit of funding, or as Libby sort of pointed to, maybe it's sharing your knowledge and your expertise, right? Maybe you're a physician and so you can participate in that manner. really the list is endless, right? So it can be tangible things, or it can be sharing knowledge, sharing experience. So really just the sky's the limits here. And the other thing is, if you are a part of an organization or association, or you're working somewhere, what can your workplace do to create a more compassionate culture, right? And workplaces in the Compassionate City Charter, which I will highlight in a little bit, workplaces are listed as an important setting to engage with when you're doing a Compassionate City initiative, because we spend so much time in our workplace, right? So now I'll move into just showing you guys some examples of initiatives all over the place, and they're going to be very different. What I will say is almost everything in my PowerPoint slide deck is clickable. So when the PowerPoint deck is shared with you guys later, you'll be able to click and explore these examples on your own. So the first one I wanted to highlight is Compassionate Ottawa. So that's here in Canada. And so this initiative is very much led by the citizens. It was started by 2 citizens who had been feeling the impact of caregiving and grief and serious illness, and decided that they wanted to do something at the community level to create that more supportive environment. And so, some of the things that they're doing, they're running advanced care planning conversations that are led by trained community members. So anybody can take their short little course, and then they support them running these conversations, and they're running in all over the place, right? They're running in churches and in condo buildings, basically anywhere that they can set up a session. One of the things that Compassionate Ottawa is doing now, since the pandemic has hit, is they do conversation with leaders, and that's all virtual and online, and anybody can attend it for free. And so they're taking on different topics. Building a shared language in the school setting. So they've done some work around starting to integrate the conversation of death and dying and grieving in the work in school community. So you can see and learn more about that on their website. Compassionate New Westminster is in Canada as well. It's out in BC, so on the far west coast of Canada. And so this initiative was led by a hospice group and is still very much supported by that hospice group. So you can see here a different approach, right? This was 2 citizens in the city of Ottawa who kicked it off. And this one here is the hospice is supporting it. And so some of the things that they're doing to really create a more compassionate New Westminster city, so they're taking that city broad approach. They're running virtual caregiver support groups, and that certainly since the pandemic. And then they're doing these 2 volunteer initiatives, Compassionate City Crew and Compassionate Helpers, which, if I remember correctly, is actually based off the Compassionate Neighbors work. So they were speaking to the group who kicked off Compassionate Neighbors, and they've gone and adapted. So this sort of supports what Libby was talking about, the idea that these can be adapted and used in different areas. And so they've got 2 versions here where they've gone through some training, but not onerous amounts of training. And it's basically citizens across New Westminster who've decided to take a more active role. And then we have a university setting here, and there's a couple more universities now who are starting to in this movement. And so Compassionate Brock University, it is in Canada. And so one of the neat things that they're doing is they've partnered up with the local hospice. So some public health students at the university have partnered up with the local hospice to present some training for teaching assistants. And really the goal there is just to give them a bit of a basic understanding of what it's like to be grieving. Like, what are the impacts on you physically, cognitively, and then how to support them, right? Point them to resources, because what we're really trying to do there is that, plant the idea that there are students who are at the university who may be dealing with, they're also caregiving, who may be dealing with someone who's dying, and they may be dealing with grief, right? So, and because teaching assistants can often be that front line before the professor, they were very interested in sort of becoming more empowered on how they could support them and where they could point them if they needed additional support. And then I just wanted to highlight some examples at an organizational levels, because we'd sort of talked about what can you do individually and what can you do as an organization. And so these two organizations here, the BC Centre Palliative Care and Hospice Palliative Care in Ontario, they are regional organizations in Canada that support a region within Canada. And so the BC Centre Palliative Care, for instance, they provide support to compassionate communities movements throughout their region. They provide seed grant funding. So I mentioned that earlier, as funding could be an opportunity if you're at an organizational level. So they provide them with seed grant funding, maybe to kick off and pilot a new initiative or what have you. They provide a lot of supportive resources to the compassionate communities within their region. And then they share the knowledge on the CC landscape in British Columbia, within Canada and internationally. So they take a bit of an advocacy role. They take a very supportive role as well. And they are a partner of the national collaboration that's supporting ComComs, or compassionate communities, in Canada. And then so Hospice Palliative Care in Ontario, the same thing. So they're supporting compassionate community initiatives within the region of Ontario. And so they're doing a lot of the similar things. I think one of the ones that's quite different is they host a community of practice that any compassionate community can attend. And in fact, I participate in that because I'm at the national level in Canada. So I participate in that every 2 months. And so that's been a really useful resource in Ontario. They're driving a provincial strategy for compassionate communities. So they're really advocating with the government. They're partnering with other like-minded organizations like Age Friendly Ontario and Dementia Friendly Ontario to really come up with a provincial strategy that would support. Because of the COVID, they've also started to provide resources that are virtual. So they've been providing those in-person resources, and now they've come up with this virtual hub. So again, all these are linkable. I'd encourage you to look at them to get a sense of all the different things that you can do or lead. Again, same thing. They're sharing their knowledge about the landscape in Ontario through an environmental scan. So they do this scan at regular intervals, and they share that knowledge about what their compassionate communities are up to. So that is a document you can download from their website. And then they're a part of that national collaboration supporting CCs in Canada. And then organizationally, continuing, so Pallium Canada, and that's where I work. So Pallium Canada is dedicated to increasing palliative care capacity across the country. And so I specifically focus on that community piece. And so, we support those leading compassionate communities. And sometimes that is with direct resources, which some of them you'll see at the end, or sometimes it's connection, or the fact that we engage regularly with HPCO and the BC Centre Palliative Care. So we're really looking to support them at a variety of different levels. We are also a partner of that national collaboration. And then we're looking to drive change in specific settings as well, because based on the work that we do, that's one of the areas where Pallium, it's an expertise. And so we are, focused on helping workplaces create a more caring culture. And then as well, we're doing some work with parishes across Canada. So increasing parishioners' understanding and knowledge of palliative care, medical terminology, and how to support each other. Another example would be Compassionate Communities UK, which I'm sure Libby is very well aware of. And so Compassionate Communities UK is another national supporting organization. And it's a group of people who've come together, and they're basically supporting and sharing their expertise across the UK, whether it's policy work, CC initiatives themselves, research and evaluation, and more. They also, if I'm not sure if you've heard of this, of the FROM model, but you can find out more about the FROM model on their website. And the FROM model is the first model, to my understanding, in the world where primary healthcare professionals and compassionate community initiatives have worked together to basically increase patients' social networks and create a better quality of life for them. So you may want to check out the FROM model, which you would find information on their website. And they also have a really great podcast. So they host the Survival of the Kindest podcast, and they post regularly, and they talk to really interesting people at different levels. Sometimes it's community developers, and then sometimes it's people doing specific work within the compassionate community space. And another example is Elevate Compassion out of the USA. So this is a fairly new group, and their focus is around fostering the compassionate communities movement in the US. And Canada, we do engage with them and chat with them quite a bit. And really, they're looking to unite collaborators across North America to create that sort of positive, compassionate culture change within the US and Canada as well. And they host monthly workshops that are free online that you could look at attending. And really the workshops are trying to share resources to help anyone who's interested in starting this work, have something that they can use to get them started. There's a lot of resources out there. There really is, to me, there's no point in starting from scratch. Check out some of these resources. I wanted to highlight the World Compassionate Communities Day that's coming up. So this is the first time this day's happened. PHPCI is supporting this day, and it'll happen annually. And so just we're aware of it. And, what could you do if you wanted to get involved? So you could look at hosting an event on that day. It could be something as easy as a conversation about starting a compassionate communities. It could be hosting a death cafe. If you haven't heard of that, you can certainly Google that. There's a whole little really helpful guide that can help you host a death cafe. As well as really on that day, we will be working together to share examples around the world of compassionate communities initiatives and what they're up to. So it's really going to be an opportunity to stay tuned and see all the different initiatives, activities that are happening across the world. If you aren't already sort of connected around this day, I'd encourage you to go to the website and you can register to stay up to date. And I know that they will be releasing some documents, a short little guide to sort of help support anybody who wants to engage on that day. So let's talk a bit about resources, because I know, again, it really helps you get started. There's no need to start from scratch. Some of that heavy lifting has already been done. And the great thing is a lot of these will just help you get started. You can tweak them for your own context. So certainly to increase your knowledge and understanding of public health palliative care, the Compassionate City, Compassionate Communities movement in general, absolutely visit the website, become a member. We host webinars, so you can participate in those webinars. Often we're publishing new tools and resources, new articles as they become available, so you can stay up to date on that stuff. The Compassionate City Charter, so you've heard me talk about this a few times. So this is a charter that Dr. Alan Kelly here created to really create that action. And so you can access that charter on Public Health Palliative Care's website and download it and have a read through it. And what it does is it basically gives you an idea of, you know, what you'd want to be looking at to achieve that community-wide change, right? Who should you engage with? You know, it highlights schools and workplaces and faith communities, but it also talks about engaging art and social media and media. So you can really use it as what I call sort of a roadmap around building your more compassionate environment. Pallium Canada has released a Compassionate Community Startup Toolkit that's been out for a few years. It's actually going through a revamp because we keep evolving and our language keeps evolving, but you can go to our website and download that for free. The Groundswell Project, they did a big research project around what it takes to start a compassionate community. And so you can find that report in their toolkit on their website. So again, you can certainly Google that. The BC Centre of Palliative Care, who you've heard me talk about a few times, they've also released a Compassionate Communities Toolkit with lots of great resources. And one of the ones I would definitely highlight is the Compassionate Communities Index. And that acts sort of as an assessment. So saying, you know, is our community ready to take on this initiative, right? And so it helps you provide that sort of self-assessment to see if you're ready. Another toolkit that's available through Good Life, Good Death, Good Grief out of Scotland. So have a look on their website and you'll see the toolkit tab and you'd be able to walk through and have a look at their toolkit for starting compassionate communities. And then I just wanted to highlight one that's newer from Pallium. And so it's our Compassionate Community Sustainability Guide. So basically here, what we've done is we want to build off that startup toolkit. And so in Canada, there are a lot of compassionate communities that have started up. And so we wanted to support them through that social change because we know social change, culture change in communities takes a long time. And again, because a lot of these initiatives are led by volunteers, you know, if we can support them with resources and tools as much as possible, then we know that increases their likelihood of being sustainable and achieving their desired impact. So the guide itself is full of best practices for community-led sustainability. So if there's a community-led initiative running, like a compassionate community or a compassionate city, what are the best practices to make them sustainable so they're going to be around on that long haul and achieve their desired impact? And then what we've done is we put in some case studies to help you sort of understand what this means or what this looks like, and then tons of tools in there, free tools to help you implement those best practices when you need them. So, you know, as much as the startup toolkits, I'd encourage you to download right away if you're just looking to get started. I'd also say to start, download the sustainability guide, because the sustainability guide is really going to help you with those planning pieces that need to happen along with those startup conversations. So I'd encourage you to look at downloading both of them. And the sustainability guide is meant to be around on the long haul for years to come to support these initiatives. And so, you know, you may go back to it again and again and again over time. And just one of the other things I will mention around this new resource is that what we've heard at the international level is organizations who are supporting the compassionate community movement in their countries have actually also found the guide sustainability guide helpful for them themselves, right? Because sometimes they're not-for-profits and things like that. So that was sort of interesting to hear from them that they themselves, who are supporting those on the ground, actually found it was helping them as well. So check out that other resource. And then just quickly wanted to leave you with some key things to remember because, you know, creating compassionate communities, creating that culture change, it takes time. So again, share the ideas with anyone who will listen. Plant that seed. They may not be interested right away, and that's fine, but you've planted the seed, and I promise you, I've had people come back to me months later and years later saying, okay, Bonnie, I'm ready now. How can we do this, right? So just plant that seed. If they're not interested at the time, that's fine, but they will probably connect with you again. Again, the idea that caregiving, serious illness, dying, grieving, it's everybody's responsibility, not just healthcare professionals. That the compassionate community initiatives and compassionate city initiatives, you know, this movement in general is led by the citizens to create social change, right? So it's very action oriented. Compassionate community initiatives provide local support outside that provincial formal system. So it's not one or the other, as Libby has talked about, it's in conjunction. But what we're really just doing is we're just trying to give better quality of life to anybody who's on that journey. And then again, social change takes time. So therefore you have to plan, you have to get some planning in place to ensure that sustainability, to make sure that your initiative can achieve that impact, which will come, you know, a few years or more down the road. If you have any questions, you can contact me. Certainly reach out to Public Health Palliative Care. So there's a few different contact points for you there. And I know this PowerPoint deck will be shared with you. And that's it for me.
Thank you very much, Libby. Really, thank you so much. That was very informative. I think you've seen the questions. Everybody wants to start some compassionate community program in their place. So you probably, both of you will probably be getting a lot of emails and, you know, but I'm glad that you've given us quite a lot of information on how we can start planting a seed. That's very important. I liked when you said that you talk too much, because in palliative care, for example, you really have to talk too much for people to listen. You talk and talk until you're like, oh my God, because there are things that people don't want to listen to or to hear, to, you know, but then you talk too much and then eventually they say, okay, and, you know, probably do it. So that's good. Talking too much is good. And I think planting the seed is very important. Thank you so much for the lovely presentation. I'm hoping that soon we'll see ourselves almost at the same level of Canada if we follow the instructions we've been given and all those links on how we can engage our communities. So we've had very many people attending from many different countries, Kenya, different parts of Kenya, India, England, Newcastle is in England, isn't it? And Spain, Tanzania, Canada, Uganda, USA, and some have commented on the chat, while others have written questions on the Q&A. So I think we'll start with the Q&A. I know that we're running out of time, and then we'll probably also make a few comments on the chat. The first question is from Dr. Catherine Peters. She is the Senior Advocacy Officer, I don't remember if that's her new title, at the IHPC, International Center for Hospice and Palliative Care, and she's asking Libby, Dr. Libby, wonderfully clear presentation, thanks. Please clarify how the compassionate communities public health model can take the opioid disparity gap you highlighted from the Lancet Commission. This is what I work in with IHPC, and it would be great to have suggestions. Thanks. And at the same time, as you're answering Catherine Peters, I saw a conversation between the two of you about using the word citizens. Maybe you can also respond to that before you go to the next question. Yeah.
Thank you, Catherine. And it's such a key component of the response to the opioid gap. And this disparity public health response. And I think I would say first that any huge challenge in healthcare, such as the opioid gap, needs to be addressed by more than one route. And so something like the Ottawa Charter, those 5 pillars I often fall back on for kind of micro level, you know, problems within my local service to kind of huge global problems like the opioid disparity. And so, you know, you need to have, as I'm sure you know, but all the different elements to your plan. But specifically focusing on the contribution of compassionate communities and of public health approaches. I think I was reflecting, I think there's kind of 3 key things I would say for their role. I think the first thing is that you need to create a kind of groundswell of support and of kind of advocacy for and anger actually for this injustice that that people are not able to access very basic, cheap, effective management for their pain. And I think we certainly saw this in Kerala when I was working there many years ago. And I remember the local councillors coming to speak to some of the senior palliative care people, because they'd begun hearing in these local panchayat meetings, so like local government meetings, rather than just hearing people shouting about kind of the potholes and electricity blackouts that were meaning it was hard. They were beginning to say, why are we not caring for people who are dying well? Why can people not get the pain relief they deserve? Why are we having to travel 200 kilometers to a centre when people should not be traveling in this state? So people were angry. And so I think the first thing is kind of creating a sense, an awareness that this is unjust, and that that there are options, and people should galvanize that. So I think first that kind of groundswell of support that something is wrong, and then local councillors, hospitals, politicians need to listen to that. And that then can turn into kind of, there were marches, mainly supporting palliative care, but with that kind of undercurrent of action is needed. So I think the first is kind of around that galvanizing support. I guess the next thing is, even if you get the best opioid laws that allow seamless transport, and doctors are able to prescribe it easily, and pharmacists are able to dispense it, the issue is that whether doctors feel able to, whether pharmacists trust it. So tackling those opioid myths, and that's not done through policy, that's done through community conversations on street corners, in tea shops, in the farm. If the pharmacist hands it over, it's like, I wouldn't use this, it's very dangerous, it's not safe. So you need to start tackling the opioid myths, and that has to be done through groups. And using the Kerala example again, there was a lot of ideas around cancer being contagious in the early times, so people were very frightened and they wouldn't come and visit people. So actually using the networks of volunteers who were from that community, who had come to training, who knew and wanted to dispel some of these myths, they were going out and sitting in people's living rooms and saying it's not contagious, but actually chewing that betel nut is what got this facial cancer or oropharyngeal cancer now, and actually that's what we should be talking about. So you then be going in and speaking in a way that people can understand that knowledge, not just kind of top down. And then I guess the other one is, with the best will in the world, even if people really understand and don't have any opioid myths, and they've got the opioid in their house, often you take it, you get side effects, you think, I'm getting rid of this, I'm never using this again. I see this all the time in my practice. And doctors and nurses aren't always able to go out there and have all that conversation, do the follow-up. So often people have the medication, the amount of unused medication in the world is so enormous that people don't take it. Whereas if you've got volunteers and people popping in saying, just how did you try that? Oh, what's the problem? Okay, why don't we get that doctor to come back? Let's have another talk. Maybe you needed an antiemetic with it. I mean, not that volunteers would say that, but maybe there was something we could do to do that. So I think there's all the different levels of what it takes, from like opioid being made in a factory to it changing someone's pain, changing experience. So many points along that, and you need all the top-down policies, you need education, but you need that groundswell of kind of understanding, support, and I think the key thing is anger. This should be available. I deserve this.
Thank you so much. That's really very important, I think. And sometimes even as clinicians, we forget to talk to our patients about the medicine, what to expect out of. So if they get a side effect that we know it's transient, will probably go away in the next few days, they get scared because we didn't explain to them. So again, the conversations between physicians, clinicians, and the patients is very important, and anticipating the side effects that could happen and giving whatever you need to give them to be able to prevent, for example, nausea. So thank you so much. There are many steps to address, but I think there's a lot of improvement again in terms of opioid accessibility in quite a number of countries, including our own country. So thank you for that. I think the next question I'll ask Bonnie to respond to it. Esther Mwinga from Kehpca is asking, how easy was it to convince people to create networks of friends, both patients and community?
Yeah, so actually, I think Libby might share some good insight here with her Compassionate Neighbors work. So Libby, I'm going to hand that over to you first.
Yeah, well, when I came back, having spent a long time seeing the energy and how big groups of communities can work together, I came back to the UK, and I must say people were it was a very cold response. People did not think it would work. They thought it sounded utopian. It was blue sky thinking, idealistic. People didn't want to do that. And so we started not by telling people, crucially, and I think that's one of the things, isn't around ordering people to start caring for people in their lives. We went to lunch clubs, to churches, to mosques, to libraries, to cafes, and where we knew people were coming together, and we just asked them what it was like to live and die around here. What's it like? How are you? Where are people dying? Who's caring for who? What's working well? What isn't working well? And then after having that conversation, we then say, how do you think it could be better? What do you think the community's role in this? Like, obviously doctors and nurses have a big role, but what else do you think you could do? And the whole 95% rule is like, people live and die, grieve in their homes and communities, not in sterile hospital buildings. So after we did that, we then held some open days that were kind of, you didn't have to sign up, you could just come, you could understand, talk to people who are already doing it. And we would always have a huge number of people going. But I think crucially, we didn't start as a hospice going out to just telling people what to do. We went through all the local kind of community groups, all the kind of the religious groups. So we were kind of doing it through the community rather than trying to impose it on them. And people wanted to talk about this. I think that's the thing. People are already worried and think death and dying is so depressing. People will be scared off. For some people, it's too raw. But for the majority of people, they're like, actually, this stuff is so important. I want to get it right. And I want to do the right thing for my family and my community. And if it means taking a more active role, people are really keen. So I think it's about how you sell it.
Yes.
It reminds me of death cafes. No, is it death cafes? A topic for another day, but demystifying or normalizing death and that kind of thing. Yeah. Thank you.
Yeah.
Yeah.
I would just say, to build on what Libby's saying, is, I think it's also, again, local context, right? So I live in Ottawa now, which is a big city, but I was raised in a small farming community where this concept comes naturally to us, right? So it wouldn't meet such hesitation. And so, I think if you're in an area where that doesn't come naturally, or that sort of thinking, it's important to have those conversations in a safe space for them, right? And so to give an example, it would mean maybe not hosting a conversation in a hospice or somewhere they're nervous about going to, right? It would be maybe hosting a conversation about increasing your social network, but at a church or a community center, or whatever that might be. And I also think it's important to find advocates, find what in Canada, we talk a lot about champions, right? So someone who's maybe felt that experience and have them get involved and champion those conversations with people who are a bit sort of hesitant. So absolutely, it can be easy depending on local context. It can be more challenging, but I think it's not unachievable. And we've seen a couple examples right in this presentation where it is achievable. So just may take a little more work. Trust, building trust is key.
Yeah, that's important. Thank you very much. So there's a question that somebody had asked, I think, Bonnie, you answered it, about if there were any compassionate communities within their area, but they did not specify their area when I was reading the question.
Yes.
But I saw you typing the answer, and I think they responded and said, thank you. Some anonymous person again has asked about how do schools often agree to be part of compassionate community? How do you go about explaining palliative care for children? Who would like to respond to that?
I can start off, and then I'm sure Libby will jump in as well. So my experience is no, they're very hesitant to engage in that topic. I actually published a paper that sort of talks about how hard it was to get sex education in the Canadian curriculum, and how death education is even more of a challenge, right? And so, I think you come at it from different approaches. And if you look at what Compassionate Ottawa did, where their project actually started out of doing some advanced care planning sessions with the teachers and staff at a school, right? So you may have to come in different ways than you might traditionally think, right? There are some good examples of curriculum that exists that schools could incorporate. So there's one called Zippy's Friends, and then there's another one called Passport for Life, which I actually think Passport for Life started out of the UK. And so it's a curriculum in Canada that some school boards are picking up that starts to talk about supporting each other, starts to plant at a young age in elementary school those ideas of consolement and things like that. So again, it's not an easy one. I would say it's probably one of the tougher next to workplaces, but we just got to get creative in how we start that conversation. And Libby, anything from you?
Yeah, I'd say that not starting with trying to explain palliative care, you know, that's quite a hard concept, and that's depending on age. The key thing is if you're talking to 5-year-olds, it's completely different, who have, you know, they haven't got a sense of the permanence of death and kind of lots of magical thinking, or if you're looking at kind of 10-12-year-olds or kind of 15-year-olds. So obviously, depending on the age, you'd tailor it. But I would say it's not about going in with death and dying. A lot of parents are really worried, you know, they don't want their children to be upset. It's much more around how do we support each other in difficult times. That's the way in. And so, you know, most schools have got those kind of conversations. It might be about kind of, I had like personal social education as a child, but, you know, the kind of you're not looking at the subject, you're looking at who we are and what your role in a community is. How do you support people who are going through difficult times? And then you bring in loss. And most children will, you know, lose a grandparent, lose a friend, lose a pet. You know, there's different ways of approaching that, and often teachers don't know how to do that because the children are upset in school, but the teachers don't know how to do that. So you can kind of, with the teachers, say, well, let's talk about how you support a child who's grieving. Let's talk about how you can support all of their class to support that child as well, and not have them kind of ostracized because no one knows what to say. And so I'd say not going in with kind of death and dying palliative care, coming in with how do we support each other when things are difficult? What kind of things are difficult in life? Well, loss is difficult. It might be loss of a friend, loss of your home, loss of a parent, loss of, you know, it's that broader sense. And that then equips them, because those are things that will equip them in the future to know how to open a conversation with someone who's sad and how you look after them in that.
Coping skills and resiliency.
Thank you so much, sir. And please, people, Zippy's friends is not me. We just share a name.
Sorry.
But I
should take credit for it.
I take credit for it. I think it's a beautiful name, and that's why it's being used there. Yeah, so we've answered most of the questions. There have been very, very many positive comments. Everybody says thank you very much to both of you. And I've seen also both of you type in some of those chat questions and discussions. I think somebody from the US wants to start immediately, so they will be getting in touch with you. NHPCO, I've seen somebody typing about that. And the other thing is, I think somebody, this is for Howard. Howard, somebody is asking how do we keep in touch? Those who have been on this call. Some people had connectivity issues. They kept on writing to me to say that they are dropping off, but I told them they could follow it up later because it will be on Facebook and YouTube as well. So I know I've taken so much of your time, and it's odd hours. Apart from Bonnie, I think she's probably has to go to the office and work. And Libby, I think you need to rest, and all our participants, they need to rest also. I really want to say thank you so much to both of you for accepting to give this session. Actually, one of the reasons I joined Public Health Politica International is because I really wanted to kind of work on, with our communities to start compassionate communities, but we got overwhelmed some. That's why I thought it will be good at least for us to listen to this and then see how we can do it ourselves. I want to thank all the participants from the different parts of the world for your patience, for your interaction on the chat, especially for your questions and for joining us this evening. I had hoped that Maculan Atieno, who's the ED of the one who has replaced me of Kehpca, would be able to say a vote of thanks, but she has just texted me saying she is on the call listening, but she's in hospital. So she is still on the call listening, but she can't talk because she's in hospital. I don't know if she's unwell. I've texted her, so she hasn't texted back. But Maculan, also thank you, Howard and Maculan and Tim, for hosting us on your platform. And I think you've shared your contacts, Libby and Bonnie. And you shared also the website for Public Health and Politica International and many other things. People, please use those contacts. Let's work on starting compassionate communities, or even if we think they exist, let's put more fuel into them so that we actually support our patients. Like I told you, this experience I had this morning really made me feel so sad that I wasn't aware my neighbor, elderly couple, that the man was very sick. So let's be compassionate. Let's work to improve the care for our neighbors, people, citizens. I know we use the word citizens. Catherine was very concerned about that, but I think it's used in the context of everybody within a setup.
Exactly.
I don't think it would take away the immigrants, or it's just
becoming
a word,
empowered.
It's an English word, yeah. So
it's
thank you so much.
Thank you.
Yeah. So thank you so much. Thank you, Bonnie. Thank you, Libby. Thank you, Howard. Thank you, Maculan and Kehpca team, and thank you every participant who has been on this call. I wish you all a very good evening. Hopefully, next time we have this session, we'll be done presenting to both of you that we've started these compassionate communities in India, in the US, in Kenya, in Kampala, and other countries, Tanzania, that joined this session today, and Spain as well, and more in the UK and more in Canada as well. Thank you so much. Thank you.
Thank you. Thank you.
Thank you for having us. Plant that seed.
Thank you.
Goodbye.
Bye, everybody.
Have a good day. Bye. Thank you.
Bye.